Welcome back to Confused Neuron. Have you ever wondered how we actually fight back against the things making us sick? Today, we are diving into a brand new explainer, exploring the fascinating medical progression from treating a violent everyday reflex like vomiting all the way to attacking microscopic bacterial and viral invaders like upper respiratory tract infections right at their source. Imagine grabbing a whiteboard marker and drawing out the ultimate battle plan for the human body. Well, that's exactly what we're going to do right now. But first, a quick question for you to ponder. What is the actual most dangerous thing about vomiting? I'll give you a hint. It's not the mess, and it's not even the damage it can do to your teeth over time. Nope. It's the massive electrolyte imbalance and volume depletion that can literally turn you into a vegetable or cause severe cardiac arrhythmias if left unchecked. Vomiting is incredibly taxing on the human body. So, here's our roadmap for today's targeted strike on disease. Anatomy of a reflex, blocking the urge to puke, principles of selective toxicity, the antibiotic arsenal, defeating viral invaders, and finally, the cost of chemical warfare. Let's jump right into Section 1, Anatomy of a Reflex. To stop vomiting, you first have to understand the physical mechanics behind it. It's not just your stomach randomly deciding to act up, there is a highly coordinated neurological highway at work here. If we were drawing this out on a whiteboard, we could distill this complex neurological reflex into the simple SRACRC sequence, SRACER. It starts with a stimulus, which hits a receptor. That signal travels up the afferent nerve to the center in your central nervous system. The brain then sends a command down the efferent nerve, resulting in a response. Fun fact, in Arabic, the word sarasir actually means cockroaches, but in our bodies, this SRACR pathway is exactly how your nervous system coordinates the motor function of puking. So the crucial takeaway here is that when your vagus nerve gets irritated, maybe by a stomach bug or even by touching the back of your throat, it sends a frantic alert straight to the CTZ, the chemoreceptor trigger zone in your brainstem. It basically screams, "Get this out of my stomach!" And remarkably, your stomach itself actually relaxes during vomiting. It's your abdominal muscles and your diaphragm that powerfully contract to force everything up and out. Moving on to Section 2, blocking the urge to puke. Armed with that anatomical map, we can deploy targeted antiemetic strikes. These drugs are basically highly specialized keys fitting into very specific physiological locks to stop that reflex dead in its tracks. Different drugs cut different communication lines. Ondansetron targets the vagus nerve by blocking serotonin receptors. Metoclopramide blocks dopamine receptors right at the CTZ in the medulla, effectively keeping you out of the zone of vomiting. Meanwhile, diphenhydramine blocks histamine, calming the inner ear, which makes it perfect for motion sickness. We are chemically cutting the wires before the signal can trigger the bomb. And to remember that a drug like ondansetron targets serotonin 3 receptors, just picture yourself counting down, with a bit of dark humor. 1, 2, I always vomit on 3. Seriously, whenever you see a drug ending in cetron, you can bet the rent money it's targeting serotonin receptors to stop you from losing your lunch. All right, Section 3, Principles of Selective Toxicity. Okay, so we've treated the symptom, but what happens when the threat is actively replicating inside your body? A symptom is just an alarm bell, right? We need to go after the microscopic intruders themselves. The absolute golden rule in this phase is achieving selective toxicity. We want to completely obliterate the bug without accidentally taking down the patient. Antimicrobial therapy takes advantage of the biochemical differences between human cells and microorganisms. If a drug is selectively toxic, it zeroes in on a mechanism totally unique to the bacteria, leaving your own human cells perfectly fine. Which brings us to Section 4, the antibiotic arsenal. Let's build our defense against bacterial invaders using some heavy pharmacological artillery. Depending on the pathogen we're fighting, like those nasty respiratory bugs, we have different weapons. We can either use a sniper rifle, known as a narrow-spectrum antibiotic, think of isoniazid, which specifically targets Mycobacterium and tuberculosis. Or, if we don't know exactly what we're fighting, we can drop a broad-spectrum bomb like tetracycline, which wipes out a massive swath of both gram-positive and gram-negative bugs. The catch? A broad-spectrum bomb can also take out the good, normal flora in your gut, leading to some pretty nasty opportunistic superinfections. This is exactly why dosing is so absolutely critical. Selective toxicity is rarely absolute. Give a patient too little of the antibiotic, and the bacteria simply mutate, develop resistance, and laugh at you. Give them too much, and that selective toxicity breaks down entirely, causing severe collateral damage and toxicity to the host's own organs. Next up, Section 5, defeating viral invaders. But what if the invader isn't a bacteria? Viruses that cause severe upper respiratory tract infections, like influenza A and B, are sneaky. They are obligate intracellular parasites that physically hijack our cells, making them incredibly tough to kill safely. Because to kill the virus, you risk killing the host cell it's hiding inside, but we've cleverly engineered drugs to bypass this problem. Drugs like oseltamivir, which you probably know as Tamiflu, work by blocking an enzyme called neuraminidase. Neuraminidase is the very thing newly formed flu viruses use to break out of the host cell. So by blocking it, we literally trap the newly formed viruses inside, preventing them from spreading. We also have ribavirin, a broad-spectrum antiviral that disrupts viral RNA and DNA synthesis for even more severe infections. Now, something you absolutely have to keep in mind is how the body gets rid of these weapons. Antivirals like oseltamivir and emantadine are quickly processed and excreted practically unchanged right through the kidneys and bladder. This pharmacokinetic detail is a massive deal because if you have a patient with renal issues or declining kidney function, that drug is going to build up in their system incredibly fast, leading to some serious unwanted toxicity. Finally, Section 6. The cost of chemical warfare. Of course, these chemical-targeted strikes don't come without a cost to the human battlefield. Every single drug has a side effect. From the violent vomiting induced by chemotherapy, which targets rapidly dividing cells like those in your GI tract, to the kidney and hearing damage caused by heavy-duty antibiotics like aminoglycosides, side effects are just the price of war. And we certainly can't forget the hilarious but highly dangerous anticholinergic overdose mnemonic. Hot as a hare, blind as a bat, dry as a bone, mad as a hatter, full as a flask. If you block too many of those parasympathetic receptors, your body basically dries up, overheats, and completely loses its mind. So I want to leave you with this provocative thought to chew on. As our microscopic enemies continuously learn, mutate, and evade our absolute best drugs, what wild, unprecedented new pharmacological weapons will we need to invent next just to survive? The arms race between human ingenuity and microscopic evolution is far from over. Thanks for joining me for this explainer here on Confused Neuron. Keep learning, keep questioning, and I'll see you in the next one.